Sriram is a heavy mentor, he's not so, and all the senior faculty were here.
This is a total point.
Now, I've been thoroughly asked to speak about how to go with exams. I don't say that eat well, sleep well, exam or rest well. That instructions I won't be done. But the problem starts with history. When you're presenting, you are examining, of course, in a neutral environment. If it is DMV, if it is DMV, your own medical college, if it is your own institution, so there's no problem. But the problem is the examiners, not the student. The examiners have to go through because especially if there are 4 cases as we are going back to the old system. It happens. The present system, the DMV seems to be good, and the DM is the same. So the problem is that they have to sit through the whole thing, and when it comes to the 4th candidate or the candidate who presents a little later, they become restless. They cannot be waiting for a very large amount of. So when you are presenting first the history before you approach the patient, how do you present the history? The history is what the patient will give. Of course, traditionally we've been taught that we should present complaints and their duration, history of present illness and go back to the past. But this may not work here because simply, I'll tell you an example. A patient has had rheumatic heart disease. She becomes pregnant, then she gets into a problem. She has a balloon vaginoplasty, and then she comes. So history cannot be presented with now saying that she is having dyspnea, and then you go back to start the history from the time she had almost a rheumatic fever, the first episode of rheumatic. There's nothing wrong in that. That if you give a complete detail, and more so in congenital heart disease, I just come and look at that. So from that time onwards, what has happened to the patient, why she underwent vaginoplasty, what were the symptoms at that time, post-vaginoplasty, what are the symptoms. So that will give the examiners a complete instead of going back and forth from history of present illness, back to past illness, back to rheumatic fever history. That you cannot have time to present, although it is traditional, you don't want to deviate, but still, the exam you have to abbreviate and you have to present in such a way that it's like a capsule form to the examiner so he knows what is to be expected. Same thing with congenital heart disease. Congenital heart disease in adult might have had problems from childhood. Start from the date of his history and from birth and neonatal history. And what are the problems of symptoms, signs of heart failure or symptoms of heart failure at birth. And then proceed. No harm at all. More important, always mention that the history is taken from somebody, it's a reliable history, especially in the heart disease. So that will give the examiners that you have taken a reliable history of that. If it is not reliable, we say it's not. So that is one thing about the history. And always don't dwell too much on the theoretical aspects. Whatever the patient says, you can. For example, dyspnea means you like to talk anything about dyspnea. It's not necessary. Only the relevant history, dyspnea, orthopnea, PNT, like that only you have to get. That's an important. Now coming to the examination is the most important part, and you should go, in an orderly fashion. Certain things you cannot afford to miss, and remember that. And the first thing is, of course, the GVP. If you miss the GVP, and the case is a constrictive pericarditis, it's a really problem. Everything revolves around that GVP and the waves which are there in constrictive pericarditis. Similarly, the pulse. The pulse, you have to make a mention. If it is aortoarteritis, you have to take a detailed pulse. If there is a case, we will discuss how to take a detailed vascular system examination, starting from the institution controls down to the. So that has to be presented in a very orderly fashion, not just say that somebody is felt or not felt and break the thing. So that those things have to be present. Third thing is that when you are presenting the examination, examiners will stop you at any time because they are not known that you have to follow what they say. If you are presenting epically, they will say, what about the GVP? So don't get flustered by that. You come back to that again and say exactly what, or you think, what have I missed that the examiner is now saying, what about the GVP? So that this thing don't get flustered if the examiner goes back and forth. Normally, most of the examiners do not wait till you finish the history. And because your line of thought also is interrupted by that. But still, try to formulate the approach to patient approach to the patient will vary. It's a rheumatic heart disease, you know, the traditional approach. Congenital heart disease, it's a slightly a different approach. So shortcuts are in congenital heart disease, but it has to tell you how to do it. Straight away see whether there's PAH or not. If there is no PAH, then it's you have to think about it. So like that, you have to adopt some shortcut methods during your examination, but present it in an orderly fashion, as is your done. And similarly, ECG actually has to be learned thoroughly, because if you make mistakes, simple things like access, everybody can say it's a cyber syndrome or not. You must be able to point out access. Congenital heart disease, you must point out what is the configuration, what is the rotation. All this you have to prepare yourself, and then of course if you taught, you would have been taught, but don't make mistakes in that. For example, if you have a VSB in the cardiac the ECG will give us two. Look here, you have a frontal plane who has access to taking also clockwise. It has to be in the endocardic. So like that, learn the axis and the frontal plane rotations. That is important. Chest X-ray, I'm sure there will be a detailed class. But always report it in orderly fashion. You don't have to say anything. But sometimes the examiners won't have time. They say, no, just tell me whether it's not particular. Then also you please tell about the judgment, the criteria which you have employed to say that that is the criteria. So that's the thing. Of course, for CAP and also I will tell you how to interpret CAP findings very well. Others will also. So with that I have finished. Coming to differential diagnosis, that's one thing which examiners, what do you think means? They will put everything. Valvular heart disease, myocardial disease, pulmonary arterial hypertension, and everything. Please don't put like that. Put something which are only relevant to the disease. If the patient has history of rheumatic heart disease, finished. You don't have to put hypertrophic cardiomyopathy in the differential diagnosis. It may happen, but then you should not think that the case will be like that. Put only the concise diagnosis which are there. And certain things, you know, if there is a hypertrophic cardiomyopathy, typical case, you don't have to worry. And certain diagnosis you have to mention. For example, if you have an Eisenmenger syndrome, don't say Eisenmenger. It creates an impression as if you know the case. Say severe pulmonary arterial hypertension. Start like that. And come to the differential diagnosis, right? So that is an important thing to know. Similarly, there are some problems when you talk about HOC. Whether you say congenital or acquired, always there are some problems. It is structural heart disease. That's what it is. It is a structural heart disease. So like that, you should learn how to give your precise provisional diagnosis as well as differential diagnosis. So with this, and don't forget management, go orderly even in management. This is the last lot of questions. Nowadays, the stress is on management many times. The stress is on echo also. Because combined valvular heart disease, echo assessment is paramount importance to judge whether the patient is going for surgery or not. So you must learn to interpret the echo, and so combined valvular heart disease echo is always a problem. It's not that straightforward. Sometimes you may have to resort to other investigations also. So with this word, if there are any questions I can answer, otherwise we'll go ahead and as Dr. Rathod says, which I missed. Sriram wants to say or any other people.
Sorry, I just want to add two more points to what Dr. Balachander very nicely alluded to. One is, we all know that the components of cardiovascular system examination are inspection, palpation, percussion, and observation, isn't it? We often forget the fifth component of examination, which is contemplation. We often find that the student just rushes into the viva without having thought about what he's done. So I would request you that always spare 5 minutes of the time allotted to think about what you're going to speak. The second thing is, as time runs out, very often examiners will just, when you start presenting, the first question they'll ask you is, okay, what's your diagnosis? First question. And then they'll say, okay, tell us relevant findings which support your diagnosis. Particularly in a short case, when end of the day, examiners want to rush through, they've already decided whether they're going to pass you or fail you. So be prepared for this. You know, suppose an examiner shoots this question, what is your diagnosis and what are the findings supporting it? So be prepared for that in a very abbreviated, brief manner. This is a question which many examiners will often approach the presentation like this. Thank you.